thank you, Claire, and to the Longevity Group for having me. I absolutely love bones, so and yet I am not an orthopaedic surgeon. So I'm really pleased to be able to speak on this topic. To let you know a little bit about me, I am a sport and exercise medicine doctor. Some of you may never have come across one of us. I do indeed work in sport. This is my lovely rugby team that I support, Harlequins Women's Rugby Team. Please check the PWR League out. We are heading to professionalisation, hopefully, at some stage. But I work in women's rugby. I work for FIFA on their female health project, which is fantastically exciting because essentially as women's football grows, considerations around female physiology are absolutely fundamental to supporting female athletes in their performance. And I also work across the way at the Institute for Sport, Exercise and Health. As an SEM consultant, I predominantly see issues related to musculoskeletal health, injury or barriers to exercise participation. So it's quite broad, but everything that underpins my practice is female physiology. So it's great to see that reflected in the talks before me. I'm going to start by making the case for why we shouldn't overlook bone as an aspect of our health as we age. I'm going to introduce to you, if you don't already know them, the sex differences around musculoskeletal health. And then start looking into the hormonal factors that are relevant and the lifestyle factors. And much of this won't be new to you. It's just bringing it all together again and echoing quite a lot of what has already been said, especially by Louise. And then we'll bring it all together and integrate all those factors as a how-to guide when it comes to aging well regarding bone health. It's really easy to overlook bone. It's not a particularly sexy topic unless you are an orthopaedic surgeon, and then it definitely is your bag. There are a lot of misconceptions, but it's very invisible. Unless it's causing you a problem, you're not really going to know if anything's going particularly wrong or, not to fearmonger, not quite optimum. We don't have very many visible cues beyond pain. And then even if we do have pain, it can sometimes be very unclear where that pain is coming from and whether that pain is in fact bony unless you've got a frank fracture. Society definitely shifts our focus when we consider aging to the more visible, on the surface, skin, hair, weight, change in body composition, for example. And many of us will be victim to forgetting a lot about the silent factors of our health. And that's not just related to bone, but the world doesn't make it particularly easy for us to prioritise or even consider our bone health. And in terms of a lack of education, I mean, I would love to see a raise of hands of anyone who feels like they understand bone health particularly well. If you're doctors, I'm sorry, you probably do, but very few. One hand up. Two hands up, great, more, yes, okay, 5, 6. I would have put my hand down even upon finishing my medical training and becoming a consultant. And I did a specialty where you are taught about musculoskeletal health. Injuries is what we do. We manage injuries on pitch, in clinic, everywhere. I don't know if you would be surprised. I'm not surprised. Not at one point in my training did I receive any female-specific information, education, evidence relating to musculoskeletal health and injury. It's only now, as I'm finding this subspecialty and surrounding myself by researchers, specifically physiologists actually, so not just doctors, who are researching female physiology as it applies to sport and exercise in female athletes, and that's not just performance, it's health and injury risk as well, that I am starting to understand it more. Consider the very many health professionals that might see musculoskeletal disorders or bone health issues in their clinic rooms, predominantly GPs, who we know are faced with 40% of their workload being musculoskeletal issues. There is a huge gap, gender gap, in education relating to musculoskeletal health and bone health, and that's everybody, healthcare professionals and the general population. And then, of course, we also lack an understanding of general female hormone health. And no big surprise, there's a huge link between the two. But did you know that bone is an endocrine organ, i.e. it produces hormones itself? New to anybody? Yeah. This is a huge part of bony function beyond the mechanical that we are not taught and is not well understood. This is gatekept by reproductive endocrine consultants and metabolic bone specialists. We don't talk about it. But if the sort of holistic environment in which your bone exists is optimal, your bone will help regulate your glucose levels and will help with fat metabolism through a hormone called osteocalcin. It will help regulate your vitamin D and calcium levels. It directly impacts the absorption of calcium from the gut and the conversion of vitamin D through the kidneys. And it indirectly, through this symbiotic relationship with other hormonal pathways in the body, supports energy availability and its own physiological function. So it puts the work in to get the good stuff out of your body. Women, unfortunately, are at particular risk of certain musculoskeletal issues. We've heard about osteoporosis as it relates to the peri and postmenopause. And this is related to low bone mineral density for age. When you consider osteoporosis, always know that that term relates to menopause. Before that, it is very possible to have low bone mineral density for your age, but it is termed just that. Okay. It can be a sign of bony dysfunction. So if your bone mineral density is reduced, your bony endocrine function, that I'm getting mad. Brainful. I also have early menopause, I should tell you all. Osteocalcin, which I order all the time in my clinic. That's embarrassing. So yes, it can be a sign that that endocrine function of the bone is diminishing or is stretched a little bit. But also osteoarthritis. I'm not sure if many of you are aware, but there is a discrepancy in the presentation of osteoarthritis between men and women, and it's very interesting. I see it a lot in my clinic, and I'm going to present you a case at the end just to sort of highlight it. And then inflammatory arthritis. We know there are sex differences in the presentation of inflammatory arthritis. Particularly with rheumatoid arthritis, there's a predominance in women, in the female sex, and lupus. And I've just written psoriatic arthritis. Some of you might have heard of these inflammatory autoimmune arthritis. Psoriatic arthritis is one of those that it might be, but it might not be related to psoriasis on your skin. Typically, something like this, something like ankylosing spondylitis, which affects the spine predominantly, tends to have this male bias. But what we know is that the presentation in women is actually atypical. It's atypical to men, that's the medical terminology. It's just different. And I think we don't pick it up as much as a result. So, thanks to Louise for sort of giving you that foundational information around osteoporosis and hormonal health. I've just pulled some data from the WHO here and just popped it on the screen for you. But essentially what it's showing you is that risk... up the top here is essentially the estimated lifetime risk of fracture in Caucasian men and women, so a very specific group of people, at the age of 50, and this comes from Rochester in the USA, maybe a comparative group to London, probably not because this is a big city, but you can see that the rate in proximal femur, so right at the top here of the femur, the vertebra usually low down, but even thoracic in the mid-back, and the distal forearm at the wrist, are as great as 4 or 5 times greater in women than men. There is reason for that. The estimates of hip fracture by gender between 1950 and 2025, you can see they're going up. But by gender in women on this side and men on the other side, you can see that despite being in different areas of the world, so the different colour or the different grayscale bar denotes a different area of the world, it's very clear that women are at higher risk of hip fracture. We know from what Louise said that that is a very, very serious injury to have, and we are taught as clinicians training that 1/3 of individuals who have a neck of femur fracture will unfortunately die as a result, either at the time or very soon after. 1/3 will have a significant change to their mobility and their quality of life as a result, and their 1 year longevity or mortality risk, longevity reduced, mortality risk up, and only 1/3 are likely to survive and benefit from that surgical intervention that they have. So it's really, really significant event if it happens, and to see that the rates are so different between the sexes and also are increasing, it is concerning. There are sex differences in bone strength, but it's not just about bone mineral density. So when we talk about measuring osteoporosis or giving you a diagnosis, typically that's done on a bone density scan, and it measures a cross-sectional area of mineralization. That's just one feature of bone strength. And we talked about bone function. Nobody ever talks about the endocrine bone function. We know that sort of geometrically, morphologically, the bones are different between men and women. They're typically slighter, the pelvis is wider, the bone thickness is reduced between men and women, but also even at the physiological level, things are different in relation to the hormones that we are exposed to. Osteoarthritis it is a concern of mine, and as I said earlier, in training we aren't really taught about, despite being musculoskeletal professionals, that sex difference, the discrepancy, and the mechanisms underpinning that difference, i.e. how we might treat women and men differently. Females are generally at higher risk of osteoarthritis than men, particularly in the knee and at the base of the thumb. Osteoarthritis has typically been talked about as not being an inflammatory condition. However, recently a consensus amongst musculoskeletal health professionals is that absolutely it is associated with inflammation. And it is at the level of the cartilage and can affect the synovium, so the capsule, the fluid-producing capsule around the joint that typically would be affected in a rheumatoid arthritis. They are quite similar, it's just the way that it is distributed through the body is different, usually 1 or 2 joints here and there, or different joints in the fingers compared to rheumatoid arthritis. So there are ways of unpicking it. But what's interesting is it's typically around menopausal age that osteoarthritis in women starts presenting. And it presents very differently to men insofar as a woman might walk into clinic with extremely severe and limiting symptoms, have swollen joints, and appear functionally. So an example would be in my clinic, I would examine how somebody can walk, and I would look to see if somebody can raise their heels off the ground. They've got the strength in their calves to help them ambulate. Often women present with a complete functional deficiency in terms of their gait and their strength, and that can be driven simply hormonally at every level: joint, cartilage, muscle and tendon. And yet these women are put into orthopaedic clinics and listed for joint replacements. What's interesting is sometimes you might image with an X-ray, and that's usually diagnostic. So as you can see on the screen here, the classification or the categorization of osteoarthritis involves a narrowing of the joint space and some whitening, some sclerosis at the joint line. Often in the early stages, despite all the swelling and despite the functional impairment of walking, the X-ray is normal. And so you can imagine what might happen in that consultation. There is pain, but there's no source for the pain structurally. And so it might be that you're anxious and stressed and have low mood because you've lost your ability to walk or exercise, or generally, if you're menopausal, there will be other reasons why you might be struggling from a well-being perspective. And I fear these cases might be overlooked. And actually, we have evidence to suggests that HRT is helpful in the management of osteoarthritis at the base of the thumb and the knee, and that it can slow disease progression and offset the need for a joint replacement. However, if you look at the National Joint Registry from in the UK for this year, this is their annual report, you will see a lot of data that suggests that women undergo a higher number of joint replacements and that their outcomes are poorer and the requirement for follow-up following these procedures is longer. I'm actually going to skip over this one and move on. So I'm going to just focus on female hormones, lifestyle, and bone strength rather than the endocrine function for now. So bone density in women is really important, and this graph shows you the rate at which we lay down bone stock, putting money in the bank, increasing our bone mass across the lifetime. We start early on at a similar rate to men, so women in the pink, men in the blue. Similar rate of growth, usually driven by thyroid hormone and testosterone. And then around the age when you are hopefully starting your periods indicating you're ovulating, hopefully, and producing estrogen at the level of the ovary, the rate of bone mass development increases. So it's a really key phase. And then by the age of 20, you've roughly laid down 90% of your bone stock in that time. And then up until the age of 30, you're laying down the rest of it, at which point there's a slow decline towards the menopause, at which point there's a huge decline in terms of rate of change. I see women, girls, in clinic and in the sports I work in, across the life cycle. Bone is a common theme in terms of the injuries that I would see. I worked at the Royal Ballet School, and so you can imagine at a phase where growth and development, maturation, particularly of that hormonal axis that's associated with periods and menstrual cycling, if you are not exposed to regular production of estrogen and testosterone, you won't be laying down your bone stock. And as an athlete or a regular exerciser, what happens at that point is your capacity to tolerate load in your bone is less than the amount of activity or impact force that you're exposing it to. And at that point, there's a risk of what we call bone stress injury or stress fracture. Through that phase, it's really important that our goal is to accrue bone mass for the future. And then beyond that, our goal is to maintain that bone mass. Some of that peak is genetically driven, you can't change it. But a lot of it will be to do with lifestyle and particularly around maintaining regular periods. So we've talked about menarche, which is essentially starting your period. The age of menarche, of starting period, is really important because it denotes the time you've spent being exposed to regular estrogen levels. There are a number of reasons why menarche might be delayed, and in the exercising population, that might be to do with energy balance. In athletes, we are concerned if periods haven't started by the age of 15, particularly in impact-exposing activities such as ballet, running, athletics, and more. And then the menopause, and I'm not going to go over that too much because Louise has spoken brilliantly on that. But to give you an idea of why estrogen at the level of the bone is so important is because it helps with this ratio, this relationship of bone formation and bone resorption. So to break that down, day to day, all the time, your bone is active. It's never static, it's always working at a sort of microscopic level. You are constantly cleaning away dead bone that is not required or injured bone, and you are constantly, hopefully, forming enough bone to replace it, and that's a homeostatic mechanism. Estrogen down-regulates the resorption, the cells that eat away the bone, osteoclasts, and it promotes the activity of bone-building cells, the osteoblasts. Another period of life at which women are at risk of lowering their bone mineral density is in the perinatal phase, during pregnancy, and also whilst breastfeeding. Sometimes this can span more than 2 years in a row, and then you might get pregnant again and breastfeed again. So this is an often overlooked risk factor for the future development of low bone mineral density for age or osteoporosis in older life. And I have a case that I'm going to present to you on that. But physical activity participation throughout this time is a really key point that I'll come to. There's a spectrum of exercise participation on a spectrum of energy stress. Lots of exercise, enough exercise, too little, and that is a very individualized equation. This image on the right reminds me of sort of 2013, 2014, when on social media everything was about Fitspo, clean eating, essentially overtraining and underfueling. And it was normalized and it was glamorized. But overtraining, exercise compulsion, beyond being an athlete, and sometimes even in athletes, is abnormal, and related to aerobic activity, so more cardiovascular, has a preponderance to the female sex, whereas men tend to struggle more with the sort of bodybuilding, lean muscle gaining type of exercise and eating disorder. Too little exercise we know is bad for bone and bad for general health because it drives inflammation. Lots of exercise also drives inflammation. And knowing where you need to be can be really difficult, but knowing what the risks might be of doing too much and what the signs are, particularly too much, because that's a lot of what I see in clinic, can be really helpful. We know that enough exercise, the right type, the right duration, the right intensity, will help with weight management, healthy weight maintenance, with good hormonal regulation, enhanced metabolism, so sort of supportive metabolism, a reduction in stress hormones, because it's very good at doing that, as well as also increasing those happy hormones of endorphins. Exercise actually promotes ovulation in the right amount. If you do too much, it will suppress the hormonal axes that promote ovulation, and if you do too little, through insulin insensitivity, through chronic inflammation and other factors, you will also inhibit ovulation. So the right amount is really key. Impact activity, walking, running, jumping, even rolling, kneeling, all sorts, is really good for developing bone strength and resistance, muscle resistance training. I've spoken about that kind of energy stress spectrum. It's really important if you know people or you are a clinician and you see patients to understand the hormonal metabolic effects of overtraining and underfueling, as well as you know the effects of obesity, for example. I feel like this gets overlooked. The UK Physical Activity Guidelines do promote bone and muscle building exercise. They call it resistance balance exercises twice a week. They say at least 15 minutes in a row, as well as that 150 minutes or 75 minutes accrued of vigorous intensity, 75, sorry, and moderate intensity at 150 per week. That is for health benefits. Again, it will be individual and individualized. Of course, athletes exercise way and beyond this, but that's why the other lifestyle factors and nutrition and recovery and all the things that athletes have access to means that we can support more than this. But this is a good place to start. Being outdoors, being social, getting that vitamin D, you get a lot more than just the health benefits directly related to the physical activity stimulus on your body. And those shouldn't be underplayed, but it's a great way of making it an excuse to do something that you would consider exercise if you're not a fan. I wanted to put something in about lifting heavy in older age because it can actually have a direct impact on your hormonal health. In older age groups, and this is without or in the absence of additional hormonal treatment, lifting heavy can increase testosterone levels, good for bone, good for muscle. It can increase IGF-1 levels, a hormone produced by your liver that is also bone building. The same is for other markers of testosterone metabolism. And so it's not just about reducing falls risk and directly and keeping fit and well. There is a direct impact on bone strength and physiology as well. I need to talk about carb phobia because of energy availability. We've talked about balancing the amount of exercise you're doing with the amount of food you're eating. The balance is tipped if the energy you eat is offset by too much exercise, particularly if you're a lean individual. You'll be at risk of having no energy left over to fuel your bodily systems, particularly your hormonal mechanisms in your body. This is a busy diagram, but essentially all it says is that if you have low energy availability after eating and exercise, and it's too little to support your basic physiological functions, particularly driven by low carbohydrate. Carbohydrate is not bad for you. You will shut off these downstream hormonal mechanisms that all ultimately impact bone, they impact vascular function, blood pressure, heart rate. Everything is low hormonally. And you will impact fertility as well. So this is any age. Stress is the same. Smoking and alcohol, the same. So echo further points. And just because PCOS affects women, there is an impact on bones. Some of the hormone dysfunction that is specific to PCOS does positively impact bone, like high testosterone levels and high insulin levels. But at the same time, that chronic low-grade inflammation associated with PCOS is negative to bone, and I see a lot of PCOS and bone stress injuries in clinic. So examples, this is how we might pick up bone stress injuries. This is an MRI scan of two lower legs. This is an individual who'd lost their periods and has a mix of possibly both PCOS and low energy availability. This is a postpartum lady, 6 months postpartum, breastfeeding, has a bone stress injury in her pelvis, limiting her ability to walk, which is horrendous with a small baby, but ultimately she went on to HRT. This young girl went on to HRT. And this is a lady who presented with a lump and a swelling just under her knee, who I described could not walk when she came into clinic for knee pain. What she did in fact have is a collection of fluid coming from her knee because of abnormal cartilage metabolism. She was started on HRT and has symptoms that mimicked high-grade osteoarthritis requiring bilateral knee replacement resolved. Hormone balance, physical activity, good diet, sun with sunscreen, social exposure, no sleeping, no stress, and good sleep will help. Bone density scans, big shout out for bone density scans, but also adequate hormonal testing by your physician will help contextualize any bone health or musculoskeletal issue that you have.